the first in a two-part series on radiofrequency brain lesioning for movement disorders. And today we are going to cover thalamotomy and subthalamotomy. So what is a deep brain lesion? Well, it's fairly self-explanatory. It is a small part of the brain, deep in the brain, usually encompassing the basal ganglion-related structures, that is deliberately destroyed to alter function as part of the specialty of functional neurosurgery, which is neurosurgery to alter function where there isn't an organic pathology there necessarily, mainly for movement disorders, but also for pain, epilepsy, and psychiatric disorders. And there are various ways one can make a lesion. I've put these in chronological or historical order, really. There is direct current and nodal electrolysis. There's injection of alcohol or oil or procaine or wax or other destroying substances. A part of the brain can be physically damaged, for example, by putting a little balloon in and inflating it. Leucotomes have been used to perform leucotomy, essentially a mechanical sweep of a bit of brain, classically for psychiatric disorders over half a century ago. A cryoprobe can deliver liquid nitrogen or another cold substance to a part of brain to destroy it. And then we have ultrasound, which I put chronologically a bit earlier because the initial apparatus for ultrasound were around about the 1950s when they were first used with craniotomies for access. And then radiofrequency, a procedure that was first used in patients in the 1950s and which we will talk about, and hasn't changed too much. What has changed in the main has been the advances in imaging that we'll talk about. Then interstitial radiation, one can put little radioactive particles into the brain itself. Focused radiation from outside sources such as gamma knife or Linac side knife proton beam. And focused ultrasound, which is something which has brought lesioning back into the public domain as a popular therapy. And then most recently, the application of lasers to damage focal bits of brain, which is receiving some attention in epilepsy. So we're focusing on radiofrequency lesioning, but ultrasound has brought lesioning to the fore in movement disorders again. And this is a recent paper from the New England Journal of Medicine, a small randomized trial. And in summary from the abstract, it suggests that those patients suitable for lesioning in the context of subthalamotomy and Parkinson's are those who are not suitable for deep brain stimulation, who seek a unilateral treatment for their symptoms, but with significant side effects of dyskinesia, weakness, speech, and ataxia. I think that's a very broad brush summary of the indications for lesioning as a whole, but it kind of sets the scene for where lesioning might have a place, at least in Parkinson's disease versus deep brain stimulation. This is a polemic from a mentor of Professor Nandi's and mine, Tipu Aziz. And I put this up there because it sort of laments the demise of radiofrequency lesioning versus deep brain stimulation and ultrasound. And it makes the rather cynical suggestion that deep brain stimulation manufacturers might buy lesioning companies in order to sideline radiofrequency lesioning as a therapy. So it's heartening that a few years on from this, we should be speaking in a seminar that is supported by a company that now does both deep brain stimulation and radiofrequency lesioning, and that we can have a platform to talk about it as an effective therapy which has its indications and has its role in the surgical treatment of movement disorders. So why radiofrequency? Well, in summary, focused ultrasound is generating randomized control evidence in the modern era. You saw from that NEJM paper, it enables one to sham lesion without a cut in the skin and without a hole in the head, which is ethically more comfortable when conducting a randomized controlled trial. However, there is a large historical evidence base from radiofrequency, mainly case series, but in large numbers. There is a big cost difference between the two modalities. Broadly speaking, 20,000 euros or so gets a lesion generator, plus the consumables being about 1,000 euros per so or so, and it's an awake surgery that takes less than an hour potentially, and the costs of ultrasound are orders of magnitude greater than that, both in terms of capital cost and time in an MRI scanner. So it is potentially more accessible in the cost-limited setting. It is potentially more manageable in resource-limited settings versus deep brain stimulation and the need for repeated visits and programming. And it can be a quick, awake operation in patients who might not be fit for anything more or might not tolerate anything more. And also there's the more minor point that there is a minimal hair shave with radiofrequency lesioning. So those are some pros with regard to radiofrequency lesioning that I wanted to summarize to also set the scene. And moving on from that, I will pass you to Professor Nandi, who will talk about indications.